Okay, so good evening, everyone. We are live here. We are again live for our next SASSM Men's Health Awareness Month webinar series. And SASSM has been in the forefront for creating a lot of awareness webinars, interviewing a lot of experts, bringing a lot of experts overseas also. And for today's show, we are having Dr. Giovanni Corona, the president of SIAMS, and Dr. Vinith Malhotra with us. So both are going to take us towards obesity and the problems in the andrology field. So let me read about the CV of Dr. Vinith. Please share the CV of Dr. Vinith here. Dr. Vinith Malhotra is the clinical director and founder of Dios Hospital in Delhi. He has over the 17 years of experience as a urologist and andrologist. He has been trained at NPOS, Nadia, Gujarat. He is the expert in the pineal implant and microsurgeon. He does formulae of prostate and stone surgeries. He's a former head renal transplant in the Reproductive Hospital in New Delhi. He's an expert faculty for USACON 2020 and been invited faculty of Fertility 2019. And he has been the faculty for andrology talk on pineal processes post-priapism in the USACON 2019. He has been the convener of surgical sperm retrieval workshop at Fertility 2017 and 2018. He's been the convener at the live andrology workshop masterclass for urologists in Delhi. And he has been the invited faculty for international and national meetings on andrology. Faculty at the andrology masterclass at Nadia in 2014, 16, 17, 18, and 19. I have attended his lectures in the year of 2019 last year when I went to MP Nadia. Wonderful speaker, wonderful person. And he has been the invited interest faculty for at the TUTH hospital, Kathmandu, Nepal, and even faculty for the product. And he's been member of andrology subspecialty committee of IFS. He's been invited as a faculty for ISA in the year of 2017, 18, and 19. And he's been invited faculty of AOGD of the National Conference in Delhi as a male infertility expert. And he's author of male infertility chapters in various textbooks, articles in national and international levels. It's a pleasure to have us, Dr. Vinith Malhotra, as a moderator. Good evening, sir. So it's very happy to have you with us. Please take the show from here.
Good evening, Dr. Natesh, and thank you for the kind introduction. It's really it's so pleasurable to actually have this kind of a SASSM e-school webinar series where we have faculties invited from all over the world, experts in the field, and to talk about subjects which are less discussed. So I would think what we are actually addressing today is a far less discussed topic of impact of obesity on andrological issues related to sexual dysfunction and infertility. And we understand big is not always beautiful. And today we have an expert faculty, Dr. Giovanni Corona, to guide us through this. Can we have his CV slide, please, Nick? So today we have Dr. Corona from the beautiful city of Bologna in Italy talking to us about the impact of obesity on andrological issues. Can we have the CV slide, please, Nick? He is an endocrinologist and andrologist at the endourology unit of Maggiore Bologna Hospital in Bologna, Italy. Current president of the Italian Society of Andrology and Sexual Medicine. Current chair of the Scientific Committee of European Society for Sexual Medicine. He is current co-chair of the Guideline Committee of the European Academy of Andrology. He's received a host of awards, including the Excellent Award in 2009 from the European Society for Sexual Medicine. In 2013, he was given the Young Andrologist Award from the International Society of Andrology. In 2015, quoted as the top best European 30 researchers category of reproductive biomedicine by Lab Times. In 2019, he was quoted in the top 20 worldwide best authors on erectile dysfunction by the International Journal of Impotence Research. In 2019, also the most affluent scientists worldwide by PLOS Biology. in 2020 was quoted in the top best worldwide 20 authors for the category of premature ejaculation by the International Journal of Impotence Research. He's the co-author to more than 400 peer-reviewed manuscripts, different book chapters, and invited reviews in the field of endocrinology and sexual medicine. So without much further ado, I would welcome Dr. Giovanni to kindly enlighten us on this interesting subject.
So, thank you for this kind invitation. It is a pleasure and honor to be here. I'd like to thank the South Asia Society for Sexual Medicine. It is a pleasure and honor to be here. I really love your country. I've been several times, and I hope to be there face-to-face next time. As you have heard, this is a very important topic, obesity, so the impact of obesity on andrological problems. This is the very important paper published some years ago in The Lancet, body mass index trend in subject age more than 20 years old from 199 countries, 28 years from 1980 to 2008, more than 1 million subjects included. And either in men and women, there was a trend during these years of an increase in body mass index. And if we look at the South Asia regions, this is true. We have not the same problems as we have in North American and Southern Latin American, but again, as you can see, either in men or in women, there was between 1980 and 2008 a progressive increase in body mass index. But now I'd like to introduce a new concept, relatively new concept, that is called healthy obesity. This is a very important study, including more than 22,200 men and women, without any history of cardiovascular disease at the baseline. And considering different metabolic parameters, including high blood pressures, reduced HDL cholesterol, diabetes, enlarged waist circumference, or chronic inflammation as detected by C-reactive protein, the subjects were defined as metabolically healthy in the presence of no metabolic abnormalities, or at least one metabolic abnormalities, or metabolically unhealthy in the presence of 2 or more metabolic abnormalities. And during a long follow-up, the authors, even in the fully adjusted model, demonstrated that when compared to metabolically healthy non-obese subjects, those with healthy obesity mean obesity, but without metabolic disturbances, or at least one metabolic disturbances, there is no difference in the risk of overall mortality as well as cardiovascular mortality. Again, no risk, even after adjustment for well-known cardiovascular risk factors. Indeed, when we look at the cardiovascular events, the history is quite different. This is a further meta-analysis by collecting all the available trials. And in this paper, the authors confirm that either in an unadjusted as well as adjusted models, there was no risk considering overall cause mortality when metabolically healthy obese subjects were compared to normal weight individuals. But when the authors look at the cardiovascular events, indeed the risk was higher, about 50% higher in adjusted model, and about 60% higher in the adjusted model. And similar results coming from other meta-analysis. So again, essentially no risk of mortality, but looking at the cardiovascular events, again, these are other meta-analyses showing an increased risk. but the risk was much higher when complicated obesity. These are again other meta-analysis showing the risk of coronary heart disease and cardiovascular disease. In fact, when in this meta-analysis the author compare the risk between healthy obesity and complicated obesity when compared to normal weight, they found that metabolic obesity, considering cardiovascular events, was associated with an increased risk, 45% increased the risk, but the risk related to complicated obesity was much higher, more than two times higher. So the first conclusion is that healthy obesity is associated with higher cardiovascular risk when compared to normal weight, but reduced cardiovascular risk than complicated obesity. Another important point. This is another very important study, including up to 4,000 subjects from Australia, aged more than 18 years old, and about 1 out of 3, so 30.6% of people initially classified as metabolically healthy obese showed the development of obesity and complicated obesity after 10 years of follow-up. And look at the incidence of cardiovascular risk and stroke. This was almost 2 times higher in those subjects who moved from the condition of healthy obesity to the condition of complicated obesity. And this was not the case in those patients who remained in the same condition or at least improved their metabolic conditions. So again, another conclusion, probably healthy obesity could be considered a preclinical condition to complicated obesity, at least in about 30% of cases. But we also know that sexual dysfunction, and in particular erectile dysfunction, is a risk factor for forthcoming cardiovascular diseases. And this is one of the most recent meta-analyses who showed and emphasized this point. As you can see, ED is a risk factor at the baseline for cardiovascular events, for cerebrovascular events, for cardiovascular mortality, for overall mortality, as well as for acute myocardial infarction. More recent data also emphasized that infertility is not just a fertility problem, but could be considered even early marker when compared to erectile dysfunction of poor health. This is a very large study from a Danish register. As you can see, more than 5,000 men evaluated through 1977 and 2010. And from this slide, you can see the lower the sperm concentration at the baseline, so look at the blue line, the higher the risk of hospitalization. In addition, even after adjusting for confounding factors, the lower, as you can see, sperm numbers, the higher risk of hospitalization for all causes, and in particular for cardiovascular diseases. So ED and male infertility represents markers of poor health. So the question is, what is the role of complicated obesity on erectile dysfunction and male infertility? We analyze separately ED patients and patients seeking medical care for infertility. What about ED patients? This is a paper that we published some years ago in Asian Journal of Andrology, and we compare 2 different kinds of population from Florence. The general population, this is spin-off of the EMA study, a European Malaysian study, population-based study, including more than 3,400 men aged 40 to 80. and a large sample of patients seeking medical care for sexual dysfunction. These are data from the EMA study. Florence, among the 8 European centers, showed the lowest prevalence of obesity. And as you can see, also obesity increased as a function of age, peaking in the 6th decade and decreasing thereafter. In our population, only 40% of men were normal weight. The vast majority of them were overweight or obesity, and up to 2% showed morbid obesity, so body mass index higher than 35. As you can see, the higher waist circumference, the worse erectile problems. This was not the case for the body mass index, so central obesity, waist circumference, seems to play a major role in the pathogenesis of erectile dysfunction. As expected, the higher waist circumference, the lower total testosterone. And the association between enlarged waist circumference and erectile dysfunction was confirmed even after adjusting for several confounding factors, including age and including total testosterone levels. These are data from people seeking medical care for erectile dysfunction. Again, the higher waist circumference, the higher the erectile problems as detected. This is a CAD structure interview, the specific structure interview that we published and validated. Higher score means higher severity. And again, the higher waist circumference, the lower IIF-5 score. So central obesity is related to ED independent of age and testosterone levels. In addition, as expected, we also found that even after adjustment for age, the higher waist circumference, the higher glucose value, insulin resistance, so the higher ROMA index, the higher prevalence of type 2 diabetes, the higher total cholesterol, the lower HDL cholesterol, and the higher triglyceride levels. In addition, the higher pulse pressures, mean blood pressures, higher prevalence of hypertension, and higher predicted cardiovascular risk as detected by Progetto Cuore, which is specifically a cardiovascular risk engine designed for an entire population, and higher scale 1 score, meaning the organic contribution of ED. So obesity-associated morbidities, in particular complicated obesity, rather than obesity per se, seems to play the major pathogenetic role. We also followed, for a mean follow-up of 4.3 years, a subset of our population, more than 1,600, and we collected the incidence of major adverse cardiovascular events. And what we observed that in our population, about 80% suffered from major adverse cardiovascular events. In the vast majority of the cases was acute myocardial infarction, and among them, 11% of the events were fatal. In this population, we found that the larger waist circumference, the higher risk of suffering from major adverse cardiovascular events. And this was particularly true for, after adjustment for confounding factors, for waist circumference larger than 102 centimeters, and was particularly true in less complicated subjects and younger subjects, probably because the impact of ED is smoothed by the presence of associated morbidities in older subjects. So obesity-associated erectile dysfunction essentially is associated with an increased risk of forthcoming major adverse cardiovascular events, particularly in younger patients. It is also known, this is the first time, the first study which demonstrated this point, that weight loss can improve sexual function. This is a randomized study showing that in the active group, the possibility to reduce weight was able to significantly increase after 2 years IIF total score. And this is a meta-analysis on the impact of bariatric surgery published in 2017, showing again that the reduction of weight is able to increase about 4-point score in total in the erectile function domain of IIF, as well as is able to increase IIF 5 score. So weight loss improves erectile dysfunction. What about infertile couples? This is one of the most comprehensive meta-analyses published 5 years ago through the study with a total number of more than 100,000 people. As you can see, there are data from subjects or clinical subjects seeking medical care for couple infertility or general population. The data are not so convincing as for erectile dysfunction. What about normal sperm count? No effect in clinical studies and no effect in the general population. What about normal morphology? Positive effect in the clinical symptom? No in the general population. Progressive motility effect in the clinical sample? None in the general population. And fragmentation increases the risk of DNA fragmentation, obviously only in the clinical sample. So the data are essentially conflicting. What about assisted reproductive technique outcomes? The same meta-analysis showing that a trend toward a reduction of likelihood of clinical pregnancy related to obesity, which became statistically significant when the authors looked at the live birth rate. So possible deleterious effects of male obesity among couple undergoing assisted reproductive techniques. But again, this is a summary of the available meta-analysis. Not all studies confirmed this relationship, so not confirmed by the authors. What is the role of weight loss? This is one of the first pilot cohort study, including only 43 men with body mass index higher than 43. And as you can see, weight loss, in particular, at least 12% of weight loss was able to improve only sperm concentration. Another very limited number of patient study, including 15 couples. Among those patients who followed a specific diet, the pregnancy was obtained in all of them, only in 1 out of 7 of those subjects who did not follow a specific diet program. Bariatric surgery, this is another study, prospective study, including 46 patients undergoing sleeve gastrectomy, followed before and after 12 months, and again, only an improvement in sperm count. And finally, a case control study, 31 morbidly obese men undergoing gastric bypass and 23 patients not undergoing surgery. And at the end of the story, even after adjustment for confounding factors, in this paper, the improvement of sperm morphology, sperm number, and semen volume, as well as total testosterone levels, was observed. So weight loss might improve seminal parameters and fertility outcomes, but the evidence is still limited. What is the role of healthy obesity in men with ED and/or in those with infertility? And again, ED patients and males of infertile couple. This is a paper that we published last year when we specifically analyzed 2 different kinds of series of patients. More than 4,000 men seeking medical care for sexual dysfunction, and about 233 men seeking medical care for couple infertility. What about ED patients? We found that about 60% of them had a body mass index higher than 30, so were obese, and among them, almost 4% of them showed an healthy obesity. So, even in the presence of healthy obesity, when compared to healthy normal weight subjects, we found a significant reduction, essentially similar to what observed in the complicated obesity, in total testosterone calculated free testosterone. In addition, we found also an increase in andro test score. This is again a structural interview that we previously published and validated. An higher score means higher risk of hypogonadism-related symptoms and signs, and no modification of LH, meaning the presence of secondary or mixed hypogonadism. Indeed, from normal weight to complicated obesity, there was a trend toward a significant increase in the prevalence of either primary or secondary hypogonadism. And when we consider a normal weight as reference, complicated obesity and healthy obesity showed an increased risk of primary and secondary hypogonadism. But when healthy obesity was considered as the reference, secondary hypogonadism was significantly higher in complicated obesity, meaning that obesity is associated with an increased risk of mixed hypogonadism, either healthy or complicated. Complicated obesity increased the risk of secondary hypogonadism, so the presence of central pituitary hypothalamus component. As expected, we also found that healthy obesity was associated with higher insulin levels, insulin resistance, SOMA index, reduction of insulin sensitivity as detected by Quickie index, as well as higher triglyceride score, which is another index of insulin resistance. Very, very interesting. We did not find any difference in some parameters, two kinds of parameters, CAD score and an IIF5 score, regarding the symptoms, erectile dysfunction. There was an increase only or reduction considered IIF score, or in complicated obesity when compared to normal weight. But healthy obesity was already characterized by an impairment of vascular flow, in particular in inflammatory conditions. So, suggesting that healthy obesity is already characterized by a subclinical erectile dysfunction, already problems at penile vascular flow, and impairment of vascular flow, even after adjustment for confounding factors, including testosterone levels. What about mood? Only modification in complicated obesity, and mood can further worsen sexual problems in the subjects. So complicated obesity, but not healthy obesity, can impair mood. What about the role of complicated obesity in these subjects in the cardiovascular risk? Similar to what observed in the general population and in the meta-analysis that I showed you at the beginning of the talk, we did not observe any association between healthy obesity and overall mortality. But either complicated obesity and healthy obesity increased the possibility of cardiovascular events, even after adjustment for confounding factors. So healthy obesity, again, even in a high-risk population such as those patients who seek medical care for sexual dysfunction, increase the cardiovascular risk. What about male of infertile couple? As I told you, 233 men, younger than the previous one, 51 mean age in the previous one, 36 in this cohort. About 30% of them with obesity, and among them, 21% with healthy obesity. So similar to what observed in subject with erectile dysfunction or sexual dysfunction, we observed a reduction in total testosterone even in healthy obesity, an increase of androgen score, and no modification of LH. So a mixed or a secondary hypogonadism even in subject with healthy obesity seeking medical care for couple infertility. Similar to what observed in the population of subjects seeking medical care for sexual dysfunction, higher insulin levels, higher insulin resistance, lower insulin sensitivity, so lower quick index and higher HOMA index and higher triglyceride levels. So insulin resistance, healthy obesity, even in this younger population, is associated with insulin resistance. And very, very interesting, similar observation for that we have found in subjects seeking medical care for sexual dysfunction, for erectile dysfunction. No difference in the symptoms, so erectile function domain or total score of IIF 15, considering the symptoms between normal weight and healthy obesity, only an impairment in subject with complicated obesity, but we also observed a significant reduction, impairment in penile vascular flow, so flaccid peak systolic velocity and flaccid acceleration when compared to normal weight. So again, healthy obesity is associated, even in this population, with a subclinical erectile dysfunction. Another very interesting issue, prostate. We observed that when compared to normal weight, subjects with healthy obesity as well as those with complicated obesity showed an enlarged prostate volume. But only those subjects with complicated obesity reported also some ultrasound and biochemical parameters of prostatic inflammation. So higher prostate peak systolic velocity and higher concentration of interleukin 8, which is a marker of chronic inflammation in the seminal fluid. But no symptoms, no difference in the symptoms was observed. So healthy obesity is associated with enlarged prostate volume, but complicated obesity seems to be associated with the subclinical prostate inflammation, because no modification in the NIH prostate scores was observed among the three groups, but some markers of prostate inflammation were higher in those with complicated obesity. So as you know, prostate volumes increases with age, but the symptoms are present only in about 50% of cases. So why symptoms not in all subjects? It is well accepted that beside the classical component of BPH, so the dynamic and the static component, probably we should consider a further important component, so the inflammatory component. In fact, stroma prostate cells can act as antigen prostatic cells and can sustain a chronic inflammation after a triggered stimuli. And several triggered stimuli can be considered as infection agents, chemical irritation, corpora amylacera, and probably metabolic factors can play an important role in this process, as well as hormonal imbalance. So essentially, several triggered factors can in some way start prostatic inflammation, chronic prostatic inflammation within the prostate, favoring the development of benign prostatic hyperplasia and symptomatic BPH. Accordingly, in the previous study, we found that the higher prostatic peak systolic velocity, the higher body mass index, the higher interleukin H seminal fluid concentration, so the higher risk of prostatic inflammation. And in these two pilot papers, we also analyzed the impact of the metabolic abnormalities in subjects undergoing surgery for VPH, and we found that the higher number of metabolic syndrome component and the higher inflammation within the prostate, within the surgery samples. And among the different parameters composing the metabolic syndrome, we found that dyslipidemia was the best predictors of prostatic inflammation, in particular elevated triglyceride and reduced HDL cholesterol. We also confirmed this by looking at all the available studies and performing a meta-analysis showing that in those subjects with metabolic syndromes, there was an enlarged prostate volume and particularly an enlarged transitional zone, so the zone particularly linked to the development of BPH. And this was age-dependent, the older age, the higher difference in the prostate volume between subjects with or without metabolic syndromes, totally related, directly related to central obesity, the higher waist circumference, the higher difference, and related again to dyslipidemia, the lower HDL cholesterol, the larger prostate volume difference. So healthy obesity is associated with an enlarged prostate volume and complicated obesity with subclinical prostatic inflammation, and probably dyslipidemia plays the major role. What about sperm parameters? Again, as I told you, for complicated obesity, no modifications of the sperm parameters. And again, this is continuous analysis. So no relationship within sperm parameters. What about mood? Similar observation that we observed for subjects seeking medical care for sexual dysfunction. Only modification, only impairment in complicated obesity. So complicated obesity, but not healthy obesity, impairs mood. Finally, my conclusion. Obesity represents a pandemic problem, tightly related to overall mortality and cardiovascular mortality. Healthy obesity is an emerging issue, and healthy obesity subject with ED or infertility have reduced testosterone levels, subclinical erectile dysfunction, higher cardiovascular risk, and an enlarged prostate volume. Each patient seeking medical care for ED or infertility should be and must be accurately evaluated and treated for the underlying metabolic diseases in order to prevent further complications. Finally, let me thank all the people involved in our study, and particularly thank to my mentor, Professor Mario Maggi, and I thank you for your attention.
Thank you, Dr. Giovanni, for an excellent presentation and a lot of new insight into both complicated and healthy obesity, from which we have much to learn. I think we've gained a lot of fresh insight into various new issues. In fact, I'm very interested by the paper that you've presented on prostate. We have a lot of questions for you. So if we can begin with asking you, what would you recommend for a patient with normal andrological history but a high BMI? Would you have a cutoff where you would institute intervention or consider any intervention?
I think that a subject with without essentially obesity complication but with enlarged body mass index should be considered a patient at high risk for the development of sexual problems, infertility problems, and especially cardiovascular disease. So we should encourage these patients to weight loss, and we should control these patients and modify lifestyle, and especially we should correct any possible modification in dyslipidemia or glucose valus, because as I told you, about 1 out of 3 of these men can develop diabetes in the follow-up. So essentially, a patient at high risk without, although they have no complication, but should be considered patient at high risk.
And would you have a cutoff where you would say at present BMI levels, you should not undergo ART or you should not attempt ART?
I think that the cutoff should be considered the one related to obesity. So 30 kilograms under meter square of body mass index, but even patient between 25 and 30 should be strongly advised to try to weight loss.
Okay. So one of the interesting and controversial issues that we face these days is the type of weight loss method which is taken up by the patients based on recommendations. And we have things like ketogenic diets and intermittent diets and a variety of weight loss methods. Do you have your views and recommendations for those?
This is a very interesting question. Preliminary data, we have only preliminary data, can suggest that ketogenic diet can work very well in this kind of patients. But indeed, weight loss, whatever obtained if with any kind of diet, with bariatric surgery and so on, essentially can improve sexual problems, can improve testosterone levels, and can also maybe improve, I'm quite sure about this, infertility problems. But the problems related to infertility is that we have very poor papers published. So we should better investigate this aspect. But I'm quite sure that especially in a complicated obesity, the improvement of weight and lifestyle can also improve sperm parameters. So ketogenic diet, preliminary data suggests that ketogenic diet can work very well in these patients.
There's another question about weight loss medications. What do you consider, and what is your view regarding use of weight loss medications?
There are preliminary data again. For example, GLP-1 agonist can work very well, especially for improving testosterone levels. So meaning that improving testosterone levels can improve also sexual function. There are no data in my mind for infertility. There are some data with metformin, with insulin sensitizer. There are no data in my mind with new drugs such as GLT2 antagonist for diabetes, for example, but probably even this kind of drug can work better because any approach able to reduce weight can work very well. There are no controlled study using this kind of drugs, but there are several observational trials showing that these kind of drugs can work very well in improving sexual function as well as testosterone levels.
In your view, what would be the early presentations of changing from healthy to complicated obesity?
It depends. Probably the available data suggests that glucose modification should be the first abnormalities that can in some way affect subject with healthy obesity, because insulin resistance is already present since the beginning, as I showed, so probably glucose valence modification should be the first abnormalities that can happen. So the use of metformin, for example, on insulin sensitizer, even in healthy obesity, maybe can improve the final outcomes. But probably even the genetic predisposition, so genetic factors, can in some way modulate this modification. We also should be taken in mind that we recently published a paper showing that some genes involved in the development of congenital hypogonadotropic hypogonadism can also play a role in the age-dependent reduction of testosterone. So I think that genetic environment in some way can play an important role.
There is recent interest in the role of assessing 17-hydroxyprogesterone for the actual assessment of intratesticular testosterone. What is your view and comment on that? That goes almost hand in hand with insulin resistance and the rising of insulin factor 3.
Yeah, this is true. Testis can produce also insulin like 3 factors, but there are several problems regarding this kind of papers, because the current immunoassay for the evaluation of insulin 3 are very poor. So the quality of the paper can change a lot from one to another one, and we have no data on the effect of the treatment with insulin 3. So for sure, insulin 3 can be considered another player within this process, but in my mind, we should wait for better evidence.
What is your assessment of the role of using E2 levels or estradiol levels in patients with erectile dysfunction? We've used them in obese patients with infertility, but do you think it should become a standard of use in patients with erectile dysfunction, and do you think therapy directed towards that would have an effect?
The problem with the evaluation of estradiol levels is similar to insulin 3. The current immunoassay has essentially target for the evaluation of the estradiol levels at the peak of the evaluation for women. So the levels of estradiol in men are quite low. So essentially, the common immunoassay are totally unreliable for the detection of estradiols in men. So are just number. For example, the Endocrine Society as well as European Academy of Andrology guidelines are totally against with the use of estradiol evaluation as either in subject with infertility problems or in subject with erectile dysfunction. Another issue, conversely, is related to the possible influence of estradiols in obesity or metabolic disturbances dependent modification of the hypothalamus-pituitary testis axis. So SERM and aromatase inhibitors can be used as off-label treatment in order to improve testosterone levels without affecting spermatogenesis. So there are a couple of meta-analyses showing that this kind of drugs can work in subject with infertility problems who are interested at the infertility issue and they are hypogonadal. So using testosterone in some way, we further block the pituitary function by using aromatase inhibitors or SERM can improve testosterone levels as well as fertility parameters.
Do you have dietary recommendations other than a particular type of ketogenic diet, but general dietary recommendations for improvement of erectile function and fertility, which would also keep weight gain preventable?
No, the main problem is to convince the patient to follow the diet, I think, not to follow the one type of the diet, but to follow the diet and to maintain weight after reaching a reduction in weight. This is the main problem, because the vast majority of the study showed that in 2-3 years, the vast majority of the patients can reach the weight even higher when compared to weight levels before the diet. So this is the main problem. So any kind of diet can improve the parameters. Obviously, ketogenic diet can reach the results early than the other kind of diets, but we should take in mind that ketogenic diet is quite expensive. So any kind of diet is able to improve all these parameters if the patient is able to lose weight.
Okay, we have some more questions, a few more questions. Based similar to this, which is testosterone boosting nutraceutical available? Is there any comment on that?
Yeah, I think that this kind of medication are more common in your countries than in Europe. The evidence is totally poor, so I strongly do not recommend this kind of medication in some way.
There is another question about whether you mentioned that there is a increased DNA fragmentation seen with obesity. So do you have a cutoff where you would consider it safe to offer ART to such patients?
Yeah, this is another important question. Unfortunately, the cutoff values for DNA fragmentations varies among the type of assay used and countries by countries. So the most accepted cutoff is 20%. So this is what we currently use. But the evidence is good for in some way from using DNA fragmentation to perform studies, but its clinical utility in the clinical practice is still conflicting because the cutoff, there is no universal accepted cutoff. There are several kind of assays used for it. So we still need more evidence-based data.
Okay, so there's one more question. Obesity-induced vascular aging, is it reversible?
Probably yes. We found that in healthy obesity there was already a modification of penile vascular flow, for example. I'm quite sure this was the case in subjects with seeking medical care for erectile dysfunction, as well as those with couple infertility. So in subjects with couple infertility, the mean age was 36. So I'm quite sure that the improvement of weight can revert the blood modifications. This was not, I think, the same in subjects with complicated obesity.
Right. I think that is all the questions that we have received today, and I think there has been a huge learning experience for all of us. We have thoroughly enjoyed your presence here today and your talk. Thank you very much, Dr. Giovanni Corona, for this excellent presentation. I thank SASSM, Dr. Natish, Dr. Vasan, Dr. Rupan sir for this opportunity of us having this webinar on obesity and andrological problems. Back to you, Dr. Natish.
It was my pleasure. Thanks a lot for the invitation.
Thank you, Dr. Corona. Thank you, Dr. Vinit Malhotra. And thanks, Docplexus team, for once again giving us a massive support. And I thank you, audience, and meet you all on 29th for the next show with Dr. Carla Bertocci on regenerative andrology. Thanks, everyone. Take care. Bye.
Thank you.
Bye-bye.